Well, when you're dealing with a patient, we do everything from medication management and trying to get their pain down with medications to sending them to physical therapy or sending them to a surgeon or a psychiatrist. I do all the injections that anybody can do. I place needles everywhere in a human body that anybody has placed them. So if you have a pain problem from your head to your big toe and anywhere in between, and it could get better by placing a needle, I've probably done it. Each individual that you do something on is different. One of the things that we found here in our office is we do what we call long trials. So before I do something to you that's permanently going to be put into you or permanently done to you, such as spinal cord stimulation or intrathecal, we actually place a wire in your back or the wires in your back, and we let you use that and go back to work or back to your activities for 2 to 3 weeks afterwards. So we actually get to see if it works, and you get to see if it works. What we know is if we do shorter trials, like a lot of people do, oh, you'll say, wow, that's wonderful. But then they get your permanent placed and you go, wow, that's not what it was like when I had the trial. And so what we do differently in this office, we do extended trials, and that way you really feel comfortable with what you're doing. If we place that catheter in your back or we deliver the opioids to your back, we want you to get down to what we call a livable pain level. Most of my patients who are taking oral medicines will always tell me that they're in the 5 to an 8 out of 10 range in their pain. So they're always in chronic pain. And 5 out of 10 isn't pain under control. So when we put the small catheter in your back, we want your pain to be at 2 or under. And that's what we're trying to do when we get there. We're trying to get your pain back to what we call a livable level. We're trying to improve your function, decrease your pain, and restore your ability to be a part of your life. And the spine is where actual pain control is done to a large portion. And so when we're able to do what we call intrathecal management, we actually place a small catheter, which is like a small hose, into your back, and we give the medicine, the morphine, directly to the spine. And by doing that, we actually get better pain control without the side effects. So people who are on long-acting oral medications or morphine, they get constipated, so they can't go to the bathroom on a regular basis. They have to take medications to soften their stool. We also know it affects their brains, basically. It slows down their memory. They can't remember short-term lists. They can't remember a lot of things that they used to. So we get worried about even Alzheimer's in chronic opioid patients at this point in time. It affects their immune system. Patients who are on long-term opioids get sicker. It affects their sleep. Basically, people who are on opioids can't take a deep breath at night, so they get what we call sleep apnea, and they may have to have a sleep machine at night. It can affect their heart and their lungs too. So all those things are affected. So if we can take and place medication into the spine, we actually get better pain control than we can by oral medication. And a lot of my patients, they then no longer have to take the oral pain medicine, but they may not have to take other what we call adjuvant medications with it. And to the same point, we've seen patients be able to decrease their diabetes medicines and their blood pressure medicines, because if you take away the pain, there's less stress on the body.